know. And I'm trying to monitor the chat to make sure in case there's any issues. But I apologize in advance for any glitches on that end. Only so much we can do to improve our internet connection sometimes. This is a really fun talk though, and I hope it's just extremely useful. I'm going to be presenting the basics of our cognitive health assessment. We have so much more in development. I know this entire Echo series is going to be fabulous and very practical, you know, immediately to you guys, because I know you guys have a really wonderful series planned. But right now, what we have on the Dementia CareAware website is this cognitive health assessment basic training, and that's what I'm going to review for you today. So anything that you guys, if you guys decide to go on to take the training online, which we do recommend to get additional continuing education and CME credits, you'll whiz right through it. Like, I'm going to get you through the basics. I hope you feel really, really comfortable with it and see how easy and applicable it is to primary care. Having said that, I know there's always challenges, and I think maybe hopefully that comes out either in a case later or, you know, in comments and questions that we will go through later. So Manahil, thank you so much. Do you mind advancing the slide to the next one? So a big overview, I know you guys, again, a lot of you know about it, but just to point out, for those of you who don't know about the Dementia CareAware effort, which is across the state, this is a wonderful and amazing opportunity through a Medi-Cal benefit that was new as of last fall and tied to a new code that we can use, 1494F, if we do this cognitive health assessment and document it properly. I'm going to go over that, kind of what that documentation would look like. But basically, it's to play a little bit of catch up with the fact that Medicare has this cognitive assessment embedded in the annual wellness visit. I work at a primary care clinic in San Francisco in our Department of Public Health network of clinics, and we don't do the annual wellness visit. So it's not to say that everyone's necessarily even doing the annual wellness visit. But for those of our patients, most of whom live in Southern California, who are older, 65 and older, and have only Medi-Cal, we can now use this additional code to hopefully get additional reimbursement for a cognitive health assessment. So that's one wonderful thing. I think the other wonderful thing is, for this brief, wonderful period of time, the next couple of years, we also have these additional resources to be doing the Echo series, to be coaching practices, to really get, you know, a dementia screening and assessment and then care planning process in place in primary care. And no doubt this is something that our patients need and you agree with, and that's why you're here today. I think we could probably talk the whole time about how needed, you know, adequate assessment and connection to care is for our older adults with cognitive decline. But now we have a little bit of an opportunity, a little boost. So we're taking advantage of that. That's just really the big picture, that we have this wonderful opportunity for the next couple of years. Next slide, please. DementiaCareAware.org is where everything's going to be. Right now, as I mentioned, you'll see really prominently displayed ways to connect to our training. It's an online training. This wonderful gentleman greets you once you register. He's so happy you're there, as are we. We thought he really set the tone. And it's an online interactive module that we are also always welcome your feedback on. But it's pretty prominent and easy to register. And if you go to the next page, or next slide, then it'll show you start you off with a My Courses kind of menu. And since we only have one course, it's easy to order from our menu at the moment. And I just want to point out that you do have to sort of just click on this introductory information. It just opens up and then you close it and that's completed. And then you go to the Dementia CareAware. It's really the cognitive health assessment overview and basics. It's what I'm going to be reviewing right now. So again, if you go back to that training, you're going to whiz through it because I'm basically going to give you all you need here. Then ultimately, there's a very brief evaluation, which is how we're able to offer CME. So that's sort of the core package there when you register on our site. And it does say it's 90 minutes. That's approximate, and I think that's a little bit generous. But yeah, this is sort of how it would look once you get into our course interface. From here on out, I'm going to talk about the actual contents of the course. So we're going to go over what information you're going to be learning. So next slide, please. So the cognitive health assessment, much like, again, I'm just referencing it in case you have familiarity with it, the annual wellness visit. Much like the annual wellness visit, it's meant to be annual. It's meant to be a checkup on cognitive health specifically. And we really tried to, one, be evidence-based. That was, frankly, a requirement of the law, but of course, it was very important to us that we be evidence-based. But we wanted it to be practical. And the reality is when we're worried about cognitive decline, we really also need to know what the functional impact of that cognitive decline is. And I'll go over this again and again, sort of why we really tie cognition and function as a cognitive health screen overall. And then we also include a check on the person's support system in this very initial, very brief assessment. The reason is that we know for people that's a foundational piece of their care and well-being when they start to have cognitive decline. It's even a foundational piece of our assessment. So none of these are meant to be overly onerous or take a lot of time. Of course, they can. But the goal here is to focus on a brief assessment of each of these areas and sort of get a sense of if you need to do additional workup after this brief assessment. So we really planned it to be brief, to check on those three things, but with a real emphasis on cognition and function. And then we also include information in the training, and I would argue this could start to be a part of your clinical practice on how to jumpstart brain health care planning, brain health support from the medical standpoint. Okay, next slide, please. So again, I was sort of harping on cognition and function. These are pillars. The reason they're pillars is because what are we really trying to detect? We're trying to detect if our patients have dementia. Dementia is a very challenging diagnosis, no doubt about it. I think many of us feel uncomfortable getting to the point where we say, you know, Mrs. X, you have dementia, and here's why, and here's what we're going to do about it. It often takes a while. And I want to just extend my empathy, extend my understanding of why this is complex, and just remind us what we even mean when we say dementia. The reason for that is I think because it is so complex often, or seems complex, we almost, forget what all the components are. The bottom line is dementia is really a syndrome diagnosis. We are saying this person meets criteria for dementia because of these main features. We know that in the future, we're going to have clearer diagnostics about what the underlying disease is that is causing that syndrome. But for now, we're often labeling the fact that this person has evidence of this syndrome. And the criteria are laid out in the DSM. And it really, the diagnostic, diagnostic and symptoms manual, oh, that's probably wrong. I've somehow unlearned what DSM stands for. But the main point is we usually look for the two main components, which are cognitive decline and functional decline. The other key features are that they're both acquired, simply meaning that they didn't exist before. This person did not have these conditions as a young person, as a young adult. And the way that we get at whether there's an acquired cognitive decline, acquired functional decline, is going to be a different set of tools because those are sort of different domains. I think I often get the question as well, does a functional decline have to be related to the cognitive decline? Of course, that really truly is, of course, the assumption, that's the implication that this person is having functional difficulties because of the cognitive issues. But having said that, it often can be hard to tell. And so we don't necessarily need to nail that down. I mean, we don't have to be the perfect detective on that front. We just need to detect that there's a functional decline. My apologies, also the purple plus kind of starts to look like a weird sideways X. It's meant to be acquired cognitive decline and acquired functional decline. These are the pillars of how we know someone has dementia. So we need to, zero in on what is going on in those two areas. And then the last part, and this is the part that I feel like I know all my primary care colleagues and medical colleagues and primary care teams have been really good at, which is ruling out the medical stuff and serious psychiatric illness that may be presenting with a cognitive and functional decline. So making sure there's no, thyroid disease, untreated, or active substance use disorder that is presenting with these symptoms. It doesn't mean that person doesn't also have dementia, but it is something to take into account, and we do need to assess for it properly. So that is part of the criteria. But don't lose sight of the fact that the main criteria are understand if that person has a cognitive issue, an acquired decline, and understand if they have a functional decline. And that's sort of how we built our cognitive health assessment. Oh, next slide. I think the other thing to keep in mind, and we go over in the training as well, is where is dementia in relationship to all these other phenomenon and spectrum of conditions that affect cognitive performance and cognitive functioning. So there are the terms that float around are mild cognitive impairment and dementia. And of course, there's age-related decline. So like every other organ, our brain has changes as we age. In fact, some are quite good and I think people really benefit from. But overall, we know that normal age-related cognitive decline may mean that person's brain functions differently, and they have a little more difficulty in some areas like word finding or multitasking, but they are able to manage their daily functioning. The next term that you often hear is mild cognitive impairment. And what that's referring to is that you've detected that they have an abnormal decline in cognitive function. That might be on a test, if the person actually gets objective cognitive testing. It may also be a really serious symptom, like they genuinely cannot remember to manage, enough to manage their bills, or everybody's noticing that they can't remember conversations as well as before, and that it's happening more often. So a serious cognitive symptom, but when you ask them about their daily functioning, there's no report, no evidence that they're having any difficulty accomplishing daily activities. That would put the person in the category of mild cognitive impairment. And then again, dementia, which I know I just spent a lot of time talking about, you meet criteria for dementia when you do have functional decline along with the cognitive decline. And just to point out, I think if you advance on that the new terminology is mild neurocognitive disorder and major neurocognitive disorder. And that is because basically mild cognitive impairment and dementia don't necessarily sound related. They really are. The idea is that mild cognitive impairment is the preclinical stage of dementia for most people. And so they're now sort of, the terminology is catching up with that so that we're all a little clearer. Although most of us aren't as facile with these terms or using them as much still, but perhaps we should be, or we will be more and more. Okay, please advance, thank you. So I think the other thing to realize is I know for myself even often, I struggle, sometimes I'm saying dementia and the patient asks, well, at least I don't have Alzheimer's disease, or it's not really clear what the underlying cause is. Again, because, and I do try to explain this in my clinical encounters with patients, that dementia, we're describing our recognition of this clinical syndrome, that we've noticed that they're having a cognitive decline and a functional decline, but it's really a bucket term, like saying heart disease. And it's just indicating that they're most likely having symptoms because of a neurodegenerative disease. So what we think is most likely happening is that they're slowly losing brain cells, and we're seeing the impact of that. What is causing that? Well, there are many diseases, and within the bucket, the biggest ones filling up the most space are Alzheimer's disease, vascular disease affecting the brain, Lewy body dementia, and then frontotemporal dementia. But I think often clinically when we say, oh, this person has dementia, we're also kind of saying to each other, they have a neurodegenerative disease. And for most of our patients, we're not going to be able to figure out exactly which one that is. Sometimes, especially when people are milder, we can get a sense of a pattern of symptoms or a way that things have progressed that would suggest one or the other. But we know, right, that we don't, a lot of this would be only really diagnosable with brain tissue, and that's not going to happen. And for some people, they might get an autopsy, but many people won't, and we'll sort of never know. But, you know, and often figuring this out is the work of perhaps a specialist, like a dementia specialist, if we have access to one. But just to point out for clarity that we say dementia, often we mean a neurodegenerative disease, but often we don't really have the ability to nail down which one. Next slide, please. And the other thing that I always think about is the second I'm concerned that someone has, you know, these symptoms, or I'm detecting that people have cognitive decline symptoms and functional impairment, I think about, okay, how am I going to support their brain? And regardless of what might be going on underneath, what disease is causing it, the brain health maneuvers, if you will, the brain health plan is going to be the same. And that's in a lot of ways a very good thing and a very empowering thing, I think, for patients to say, we're still maybe figuring out why you're having this decline, but we know that you are having this decline. You know, you're reporting symptoms, or someone you know is reporting symptoms, and we, you know, we've found evidence that you're not doing as well maybe on this screening test. We'll keep working on this and we'll figure out what might be going on. But in the meantime, we can do a lot of things to make your brain healthier. Some of the biggest ones are hearing and vision. So hearing impairment is the biggest midlife risk factor for cognitive decline later in life. And when someone does have cognitive decline or dementia, it speeds it up if they're not correcting their hearing. So recommending a hearing test and hearing correction. Vision, most patients are very motivated around getting their vision corrected, but sometimes they just don't notice. Avoiding and taking away medications that reduce cognitive function or have cognitive side effects. The social and physical activity piece is huge. And then the stuff that you guys are already incredible at, which is managing blood pressure and diabetes to the extent that is practical and goal appropriate for someone, you know, based on age and other conditions. But that tends to help brain function as well, and certainly helps progression. And then the other thing I point out is, you know, if you're having these symptoms, we know that you might have more challenges managing other conditions. So we really do want to figure this out and really do want to support your brain as much as we can, because that will help us manage everything, you know, all your other medical conditions and just your life in general. So really focusing on these like really broad things that may not, I guess, seem super exciting in terms of dementia treatment, but there's a lot we can do. And I would start it at the beginning of a symptom, at the beginning of a positive cognitive health screen. Okay, next slide, please. Okay, so that was a lot of buildup to what is the actual cognitive health assessment. We haven't even done it yet, and I've already started talking about the plan. Maybe I'm a little cart before the horse on that, but I do think there's so much we could do kind of automatically if there's any kind of symptom. But what we're really talking about with a cognitive health assessment, remember, somebody's coming in for an annual visit, or I think I know a lot of my older patients come in much more often than that, but at some point during the year, I'm thinking, okay, well, let me go through the preventive health stuff. And cognitive health assessment is on there, or, you know, a cognitive assessment of some sort. If you're going to go forward with a cognitive health assessment, the way we've structured it, again, and on the right side, what I have is just a reminder to myself about what I would even need to know if that person has dementia at the end of the day, at the end of our workup, which is the cognitive issues, the functional issues, and then if there's other causes. We structure the cognitive health assessment to start off with a question, some sort of history of whether or not there's a symptom or someone else has noted a symptom. Then use a tool to get a little more objective. So you may have a strong sense that if someone's reporting a symptom of always losing stuff over the last year or forgetting to pay bills way more frequently over the last year, you may think to yourself, this is a pretty good reason to go ahead with a longer assessment anyway. But we recommend just a quick, objective, tool-based assessment right in the beginning. That's really quick. And then a quick question about who's in their life, who's their support system, and starting to document that. And again, this is all in the spirit of starting to chip away at these pieces that we're going to need to come back to anyway. So it's not the whole thing, but it's starting on a path, and it's sort of laying out the three things we're going to need to continue to work on. Next slide, please. So what would it look like to take the patient history? This, again, could be extremely practical. Like maybe there's a survey you already use in clinic to get a sense of senior health. So for a lot of Medi-Cal patients, we use the Staying Healthy assessment, and the senior version one has a question 20, that asks about, have you noticed any changes in your memory in the last year? But another question is, that someone on the team could ask, and it wouldn't necessarily have to be the MD or DO or PA level provider, could be, do you or others think that you're having trouble remembering things? Another question could be, during the past few years, have you or others noticed changes in your mental abilities? So it could be either something that's already on a screening assessment tool you have, or one of these questions could be added to an intake form or an initial survey for patients coming in for an annual visit. The other thing just to point out is a valid history would be noticing something. So I get a lot of referrals in my Jerry clinic for folks who just noticeably can't manage their affairs. And they're having, every visit is the same. They're not able to follow medication changes, for example. That counts, I would say, as a historical, piece of information that says this person needs a next step, has a positive symptom. And so I think just simply noting, what the symptom is, who's noticing it, what an answer to a question is, would be the first step of taking the step number one, taking the history. Next slide, please. The other thing I want to point out, if you're using the observer model, which is we are perhaps screening patients by using provider reported findings, like I've noticed they can't keep track of appointments or medication changes, is that cognitive history, a lot of these screens really focus on memory, and that's totally valid. There's a lot of memory symptoms with many types of dementia syndromes, right? But just to point out that if you carefully read the criteria for dementia, there's a lot of other domains, and we do go into this in the training a little bit and flesh it out more. So this is something you would learn a little bit more about doing the training, which is you could actually have dementia and have a perfectly preserved memory and really just be having new personality changes or behavior changes, which would be the last domain. Or you could have a lot of difficulty with language, like all of a sudden can't really, get words out. And I'm not casting aspersions, but something like Bruce Willis, who comes out and has a new aphasia later in life, that could be no specific commentary on his case. But if that were your patient, it could be an early variant of, a language presenting syndrome. So just to point out that dementia is a whole brain disease. All the neurodegenerative diseases are whole brain diseases. They just usually start in one place. And so that's why we have all these different symptoms. But they would still end up meeting criteria for dementia at some point. So that's a little sidebar, but it may be that you may want to pursue more of the cognitive health assessment if your patient is just complaining of a language issue or is having a new, really unusual behavioral symptom. Okay, next slide, please. Thank you for letting me take that detour. Okay, and then step 2 was use a tool. So whether or not the person reports a symptom and whether or not somebody else has noticed anything, the next part of the assessment would be to apply a tool. And this is where we have to still think in the cognition and function categories. So what's a tool I can use to test their cognition? What's a tool I can use to test their function or get a sense of their function? And here's where we do give people options, because no one test is perfect in all circumstances. And of course, we have such a wonderful variety of patients and what they bring to the table. So we wanted to be sure to give people options. You could also have an informant answer most of these questions, both for function and for cognition, which is why we give options for those as well. A lot of practices will use, like, while their patient is waiting, give a care partner a survey tool like the 88 or the short IQ code for a cognitive assessment. All of these were meant to be really short. The GP cog, I think many people haven't heard of. The mini cog, many people have for the patient side of things. The mini cog is a 3-item recall, and then the person does a clock draw. And the GP cog is actually quite similar. They remember an address, but it adds a couple things. They have to do a date, or tell you the date, not a date, tell you the date, a recent news item, and then draw the clock, and then remember an address that you told them, a name and an address. And so it's not much longer. The other piece of the GP cog is it has a second page that is for an informant to report on function. So that's the approach that the GP cog takes, and maybe, one way to package it for your practice. We do really recommend, generally speaking, focusing on the patient and then getting additional informant information if the patient is totally negative. At some point, you're going to have to talk to an informant, if at all possible. Many of my patients don't have anybody I could talk to, so I fully recognize that sometimes that's not possible. But when it is possible, it usually helps to give a bigger picture of what's going on with the person. But I guess if you could focus on the patient with giving them tools, and if it's way simpler for your practice, you could also have a lot of options to even start with the informant. But lots of mix and match options here. And Manahil, do you want to forward? I think I tried to animate. Yeah, so you could try just giving a different combination of tools where the patient does one half and the informant does the other, and another, or just focus on the patient. A quick review, I think many of you know that when I say function, just to be very, very clear, I'm referring to activities of daily living, instrumental activities of daily living. We give an option of sort of a checklist to go through this. And what you're really asking is, how do you accomplish these things? And has that changed in the last year or 2 years, where perhaps someone else is now helping you with some of these things? Great, next slide. So again, just to emphasize, if the patient screens negative and you're only working with the patient, that's actually kind of when it's most useful at this stage to get the informant, because you may be missing something. The person themselves may not be reporting accurately. And so that's why maybe counterintuitively we suggest that the patient's totally negative to definitely try your hardest to talk to an informant or to get them to answer one of those surveys. Because unfortunately with dementia, we do know that the person who's ill may not be a reliable reporter. So we often get informants involved. And you can move to the next slide. And then the last one we mentioned is, and again, you're sort of just kind of working through this and assessing the whole package later. So you try to get a history. Again, that's often just one brief question or someone's observation. Apply a tool to understand cognition and function. And that can be a combination of patient and informant. And then finally, a brief assessment of the person's support system. If there is someone in their life who they rely on or could be relied upon. And the reason, again, for that is not in any way to infantilize or take away the importance of the person and the patient at the center of their care, but it's just a super practical matter. And we know that the sooner we involve care partners, often the better we can establish our footing with a care plan. So the issue with presenting this, and I'm sure you guys all immediately appreciate this, is we all have a ton of people in our lives and they all have different roles. And sometimes someone comes with someone to appointments or is at least available care. They're not a direct healthcare agent. Of course, it's pretty rare, I find, to find people who have a formally documented healthcare agent, but not impossible. But they may just be an informant. They may just know, have some information that's useful about the person and are available to talk. So just sort of asking, do you have anyone who's available to speak with me and who knows me well, to sort of add to my assessment, and just kind of documenting who that person is and what role they play. That's sort of the goal of this part of the assessment. Obviously, it could get very lengthy, but that's not what we're going for here. It's more of an initial documentation of someone who might be in that person's life and can provide either support or additional information. Okay, next slide. Yes, and thank you. Okay, so then how would you document and bill? We are coming up with smart phrases that we want to, put online and people could use. I think you guys are actually way ahead of the curve. I know your team is really sophisticated around supporting EHR integration of geriatric assessments, and you probably already have a lot of this. But in order to build the requirements around documentation are really just that you have documented what screening tool you used, and it turns out for documentation purposes, they only really care about documenting which cognitive screen you used and the results. I think it's probably as useful to document the 3 parts. What was the answer to the history? What was the findings on the cognitive screen and the functional screen? And finally, who's the support system? But you need to document what tool was used, what was the result, and how would you interpret it? So like, I see someone in the chat mention the MoCA, and I will try to speak to that briefly. So like a MoCA, and the score was 16 out of 30, and I interpret that to be an abnormal screen indicating, further assessment needed. You have to document that you disclosed the results and made a plan for next steps. The requirement is really that the steps of the CHA are reviewed by the provider, but it doesn't mean that the provider had to do it all. So in fact, another person on the team could do the assessment. And again, the patient could be part of that, just filling out a form, or an informant could, and that you've collated it and you've reviewed it and interpreted it and put it in your note. Next step, or next slide. So what we're really trying to do, and we have a ton of training and development. Again, I know you guys are really well supported, especially with things like this ECHO series. But what we're trying to do is set people up to continue to work down these paths of what's going on with the cognition, what's going on with the function, what's going on with the functional, the support system, and then there's kind of a care plan implications for each. And that's really what we're trying to do. And I always think of it as a spiral. Like, I'm coming back and I'm going deeper on each of these issues every time I see the person. And they're changing throughout. I think if you forward a little bit, they're going to progress. So it's in fact worth it to keep going back to these issues, because their social situation is going to change, their cognition is going to change, their functions and functional needs are going to change. And so we sort of give you the approach to hit these main domains. And so once you've sort of done the medical workup, I really add my 3rd pillar, as you see sort of on the right of the slide, is the support system. And that's kind of how I think about sort of an ongoing framework for working through the cognitive issues. And I think that might be it. Although we do want you to have our email. You are beyond welcome to email me at any time. Although I also know you have great resources here at UCI. And I'll briefly mention or speak to this great question about the MoCA test. The MoCA is a perfectly reasonable and validated tool for primary care. I think it depends on the population. I have found in my patients, the MoCA, especially not the MoCA basic, but the MoCA, the full MoCA is just hard. Everybody doesn't do well, and that doesn't really help me sort people out as in doing well and not doing well. I end up, that it kind of tells me everyone is having an issue, if I'm to believe it, I guess I would say. So, and then the MoCA now you have to train. And there's sort of that barrier. So we didn't want to recommend it right out of the gate, because we didn't want to say, oh, everybody has to do this additional MoCA training. So that's the reason for not recommending it. But if you're super comfortable with it, if you feel like it works really well with your patient population, to help you figure out who's maybe having challenges and who's not. Totally recommend, the best tool is one you're going to use and you're comfortable with. That is
Can I have
sure.
a follow-up question about that? Can you hear me? So I
Of
actually
course.
have used that like every few weeks. I have someone come in with a concern about memory issues. Usually it's a partner or spouse that's worried the individual's forgetting things, forgetting names of people they worked with for 2 years. MoCA, I feel like, is maybe too easy. I haven't had anyone who's positive on it. So a question would be, if they get like a 28 out of 30 or 30 out of 30, but they're coming in with those complaints, is it case closed?
Right. This is the problem. Yeah, I'm fascinated by what you're saying right now, that we're living in parallel universes. But okay, yeah. The thing is, you gotta look at the patient, and the bottom line is, right, so it's really what the important factors are cultural, educational background, meaning some cultural consideration, like education in a way is almost cultural, like it forms the way you think and perform, and some on tests. And a lot of these tests might be applied to people whose educational background really isn't a good fit. Level of education, of course, is incredibly important. And then age, these things should probably be age adjusted, like norm to age, as well as norm to education level, if not possibly, like region of education. So like an urban versus a rural education from the same country might be really different, or that person might be really different. So at the end of the day, a lot of times it's how's this person doing functionally, and how, when I think of a cognitive symptom, I'm usually thinking how it's about trajectory. So how serious are the lapses? Because we all have a cognitive lapse at some point, right? Forget something somewhere, or don't perform perfectly, or have an issue. But how serious is it, and how often is it happening? And when both of those things are sort of more, it's more likely to be a real.
So my question, like
concern.
yesterday, I had a patient who has some legal training, is a very educated individual. He came in, like I mentioned, he's forgetting stuff. He's forgetting people he's worked with for 5 years. He's forgetting their names. And so his wife is worried that he's forgetting so much more. So he came in and we did a whole like slew of tests in MoCA, and he got like 29 out of 30. So am I like, do I send him home? Like, you don't have any concerning nothing to do other than, control risk factors, control, the social control, like, or is there a next step for these individuals? So this scenario I laid out, I see commonly, and I'm aware with the population that is more educated, but this happens, I'd say, like monthly. So, and it's usually the same bind, and they do well. And then I'm like, okay, well, risk factors, and those, I don't know if there's anything else we can offer these patients with their memory challenges.
So I'm sorry, Dr. Sadi.
Yeah.
I might, Dr. Chodos, if it's all right, I might just add a few things. So Dr. Sadi, I see this too in my practice, where folks who are, PhD, pharmacy, MD, attorney type of education, and they often test very well on the MoCA. But they are presenting with functional decline. So like Dr. Chodos said, I think it's really about the gravity of the functional changes and how long, the trajectory of what that looks like, and if it's worsening. And you're right to evaluate all of the, the medical issues that might be contributing, as well as mood, so any anxiety and depression. And then sometimes for these folks, I do send them on to neuropsychology for cognitive testing, because the cognitive testing that's done is normed to age and education, or it can be in many situations. And even if the patient scores, quote, normal on neuropsych testing, it does establish a baseline for future testing, like in 12 to 18 months. But we realize that not everybody has that available to them.
Would you start any medication, or is just kind of, the conservative care? Like there's no treatment for those patients I described, right?
So they're presenting with cognitive decline, as reported by their informant, but they're testing, but their MoCA score is high.
Yeah.
Yeah. I mean, I would
and
love.
Function. Yeah. Do you have any like functional issues?
No, like the gentleman yesterday, he's like, he has to, he goes to a meeting, he writes down people's names now because he's where he does forget things more often. So he does use those lifestyle, changes to as a tools, but like he does have that, like, it's a happening that he's forgetting more. I just feel like my hands are tied about any medication. I know some providers who, the word dementia memory problem comes up and it's done, it passes automatically, So I feel like I would need to have some actual data to be able to start that medication and not just based on subjective opinion. But so I'm curious, is there any treatment to give them for the dementia in this scenario, or just a risk factor management?
Well, I guess in this scenario, I'm not convinced that the patient has dementia, right? I would,
Okay.
yeah, my personal sense, and Dr. Chodos, please share if I am deviating from the norm, but I would probably send the patient on for more testing just to confirm, since the patient's functional decline and MoCA score is not congruent. And then if they do, maybe the neuropsych testing is going to show that the patient has a mild neurodegenerative disorder, or MCI. I don't generally start donepezil in MCI patients for a variety of reasons. One, I'm not really sure how effective the medication is. In patients, there really is no way to know or test for that. There are significant side effects. But lifestyle factors would probably aggressively be managed, including mood, and then follow up on regular time periods just to track progression.
Okay, thank you for clarifying. Yeah, these patients usually, even if they normal, they want to go see neuro just for second opinion. Everything's good. I'm like, all right, they can go. But and I put in my message, like I did a GAT7, the PHQ, audit, DSA, all of them, I do all that, and they're all negative. So it's just kind of like, I don't know what neuro can add, but go ahead. Okay.
Great question, Dr. Sadi. Thank you.
Yeah, so good. You're really thinking it through and getting the big picture. But yeah, I think most of us wouldn't, especially if it's functionally normal, wouldn't like focus on a medicine.
Okay, thank you for that. And another question, sorry, if a patient comes in with no complaint of memory issues or any decline, but let's say in a visit, I noticed they're asking the same question just 3 times within a half an hour. So I'm getting a sense that there's a decline. It's a little bit awkward for me to bring it up. Is there anything to do if it's not the patient's concern, not a chief complaint, but like, what's your suggestion in those scenarios?
Actually, I think part of the question cut out. I'm really sorry. Sonia, did you hear the whole question?
Yes. So I think, so Dr. Sadi, so you're noticing that the patient is repetitively asking you questions you've addressed during the medical visit.
Yeah.
They are not complaining. They don't have a concern about memory impairment.
Yes.
And how should you approach that?
Yes, because I'm noticing it, but they don't notice it and they don't care about it. It's not on their radar. I don't want to offend them. Like, what's the best way to help them in those scenarios?
I talk too much, so I don't know if does somebody else wanna. That's a lot of people, right? It's definitely clear that many people do not have insight. I usually, I point out that I'm noticing something, it's part of my job to look into it. So I'd like to, do this test or do this thing. Some people refuse, right? Or they don't want to deal with it. I would, ask if it would be okay for me to reach out to anybody in their life just to get more information and to figure out how I can support them. And then I just try to tap into other goals, like, we're really trying to work on this, and it's going to be important that we, also are able to support, your ability to manage, the issue with your housing or whatever. And I think we would we would approach this differently if you were having a little more trouble with the paperwork than maybe is obvious to you. I don't know. I try to it's a hard thing to do. I still am I guess I have a pretty, a habit of being pretty nosy and in people's business. And I just admit that I feel like that's my job to make sure I'm preparing them for all the stuff that comes up with health and wellness as they get older. And I just sort of couch it in a really general way. And I point that that's on my agenda because it's my job to make sure we're addressing, you know, head to toe health issues. But I think if people refuse, it can actually be a sign of being appropriately protective. You know, I have a lot of patients who feel like obviously it's going to mean something gets taken away if we really, some sort of autonomy, some sort of authority over their life, if we really dig into things. So I guess I respect that and make clear in my notes that I'm concerned about it. And then I work with social service partners if I have to, if there's real concern about safety in the community or something like that, like talking to adult protective services and other community resources. Do other people have like a way of really opening that door? I guess there's a public safety issue too, like if you are worried about driving, you know, it kind of depends on.
Well, that was going to be my next question. Have you ever reported anyone to the DMV? Because that's really crippling to an individual. And sometimes I feel like they may not be safe, but it's a very hard subject to bring up or to follow up on.
Yeah, that could be a whole talk. Actually, we have an expert here on driving and dementia. Camille Fitzpatrick is happily retired, but perhaps we could pull her back sometime. But you're right, it's a very difficult situation and we can definitely devote some time to that in an adequate fashion on another echo. But if you have a specific question, please email any one of us and we can help with that in the meantime. Manahil, I'm really aware of the time. This has been such a fascinating and productive hour. We want to thank Dr. Chodos. Manahil, I'm going to turn this over to you to introduce what's coming up.
Thank you. So just a few closing remarks and announcements. So if you wish to receive CMEs, please fill out the form at the following link, or you can scan the QR codes. We also ask that you complete the evaluation form, as this helps us with our continuous quality improvement efforts. This presentation and links will be sent in a follow-up email before the end of the day. And I will also send QR codes to make it easier. And also please join us next Friday, October 21st, as we will be holding office hours from 12 to 1. I will be sending out a Zoom invite at the beginning of next week. And we also hope to see you all again the Friday after that, so October 28th, for our session on cognitive assessment, identifying the most common forms of cognitive impairment. So thank you all for joining us today for our first ECHO session, and we really hope to see you all again.
Right, and just to say, office hours next week, bring any and all questions, concerns, related to dementia, let's say. Okay, all right, have a great week.
Sorry, thank you. Is it okay if I ask one more question? I don't know if you're going to have a few more seconds.
Yeah, sure, go ahead.
Sorry, I might be a silly question about the coding, because I know at our clinic we use the 99212, 3, 4, and 5 codes. So I'm not familiar with that code that you suggested. What's the difference between using that one and the 99213, 3, 4, 5s? And this usually would be a 5, given how long all these screenings would take. So
yeah, great point. And you're doing exactly the right thing. If you happen to have a patient who's Medi-Cal only and 65 and older, and not dual, then you can use this code just for doing the cognitive health assessment and documenting those components that I mentioned on that one slide. You also have to do the training that we have online and register with us. So we're exploring other ways to be able to get signed off on having done a training that would make you eligible.
So you do that in addition to the 99214 or 5, or it's separate?
Yes.
Okay, so in addition, okay. All right, yeah, okay. Thank you for clarifying.
Thanks. There's so many great questions. Obviously, we could have done this for a lot longer, and I just want to say thank you. So so honored to be here. Have a wonderful day. Although I can hang on for a couple more questions.
Does anyone else have any questions that's online? I believe that's it, Dr. Chodos. Thank you so much for joining us today and taking time out of your day to present.
Of course. Thank you. It's always so great to see everyone.
Thank you.
So
Have
much.
a great day.
Thank you.
Thank you.
Bye-bye.
Bye.